Okay, let's start with these conditions. Okay, so let's say we have phenylalanine, and phenylalanine can be converted to tyrosine. What if we have a problem? And let's discuss these diseases. What if we have a problem? Okay, so again, this is phenylalanine and this is tyrosine. What if there is an enzyme deficient here? What was the name of the enzyme? Phenylalanine hydroxylase. Hydroxylase. You know what? I usually write PAH. Phenylalanine hydroxylase. If this enzyme is deficient, that means you're not able to make tyrosine, correct? Okay. What if B6 is deficient? Same thing. Cofactor which is required for the activity of that enzyme. So let's talk about phenylalanine hydroxylase deficiency. So the disease should be called phenylalanine hydroxylase deficiency. Okay. This deficiency has a name. It's known as PKU. P stands for phenylalanine or phenyl ketonuria. Phenyl ketonuria. That's the disease. Now, let me do this. If we have deficiency of this enzyme, that means you cannot make tyrosine. Tyrosine will be decreased, correct? Tyrosine becomes what? Essential. Phenylalanine will accumulate. Because of this deficiency in PKU, phenylalanine will accumulate and tyrosine will decrease. It becomes essential. But of course, remember, tyrosine was eventually converted to melanin. And it was converted to catecholamine, which is dopamine, norepinephrine, and epinephrine. Correct? Okay. So when you have phenylalanine hydroxylase deficiency, this is what happens. Now, when phenylalanine accumulates, it will be converted to different metabolites, so you can get rid of it. And they are known as phenyl ketones. Phenyl ketones. So phenylalanine, the preferred pathway is what? To convert phenylalanine to tyrosine. That's the preferred pathway. But if that pathway is blocked, obviously phenylalanine will convert to something else. Okay, in this case it will convert to phenyl ketones. Phenyl ketones. Now, these ketones will be known as, all of them will, they're known as phenyl ketones, so they should have the name phenyl in their name. All of them, there's 3 of them. Phenyl lactate, phenyl acetone or acetate, and phenyl pyruvate. Memorize these, okay? They'll become even easier as we discuss them, especially when we reach glycolysis. So phenyl lactate, phenyl acetate, and phenyl pyruvate. That's the 3 ketones. 3 ketones. These are not normal ketones. These are abnormal ketones. Okay. The problem with that is when they start accumulating, they will cause damage of your neurons. So it's these phenyl ketones that are damaging. They become toxic. Okay, so I'll use the toxic in red. So only phenyl ketones are toxic. Phenyl ketones are toxic. See, if we convert phenylalanine to tyrosine and then it's consumed, that's good because it becomes products that are useful to us. But if you cannot convert it to tyrosine, dopamine, epinephrine, norepinephrine, or melanin, that means what? The problem is phenyl will accumulate, phenyl ketones will develop, and they're toxic. And the body cannot clear them at the same rate. So they become toxic. Now, as a result, it leads to a disease. First, we need to know PKU is deficiency of phenylalanine hydroxylase. And if it's phenylalanine hydroxylase deficiency, it's an enzyme. All enzyme deficiencies are inherited in which fashion? Recessive fashion. In this case, it's in the autosome, so it's autosomal recessive disease. So PKU, number 1, is autosomal recessive disease. Autosomal recessive disease. When you don't have this enzyme, there will be accumulation of phenyl ketones. And these phenyl ketones can be measured in urine. You can measure them in urine. That's why it's known phenyl ketonuria. Where are you finding these ketones? In urine. And why would you call it phenyl ketonuria? Blah, blah, blah. Why? Because it's found in urine. So the best test to do is what? Urine analysis. Anyways, take a sample of urine, look for these ketones. Okay. Now, problems.
Antonia?
Yeah.
I'm not so sure if this question would be relevant to what we're discussing now. But
I feel it's relevant.
does it have anything to do with the insulin receptors on the cell wall?
Insulin receptor?
Yeah. I mean, that mechanism in particular.
No. Nothing. So mental retardation is a huge complication of this condition. Mental retardation. Yes. Okay, now the enzyme deficiency is inherited. For them to have mental retardation? You see, technically you can call children up to the age of 1 mentally retarded anyways because they're not able to process, right? But it becomes obvious when you expect children to speak and think. But before that you might not be able to differentiate because you say, oh, it's just a child, it's a normal process of growth. Okay. So mental retardation, microcephaly. Okay, microcephaly. And these babies will have musty odor to them. Musty odor. So they will have an odor. And that's because of phenylacetone. Phenylacetone. Write that down. The only one that can come in form of gas and stimulate your nasal neurons and cause smell is phenylacetone. Not lactate, not pyruvate. Okay. Okay. But now, if you cannot make tyrosine, can you make melanin? No. So, if this enzyme is also deficient in, let's say, skin cells, in hair cells, of course, the person will become albino, albinism. Yeah.
Going to the right, did you say it'll become essential and the body will compensate for it? Or not to that level?
No, so when it becomes essential, meaning you need it from your diet. So you will compensate for eating diet that's rich in tyrosine. When that means female who are pregnant, they should be informed of that and they should go to counseling. If they don't, these will happen. Okay? Yeah. Alright. See, the thing is, it doesn't affect these guys that much. But it affects, so that I'll erase this part. It does not affect catecholamine because you can get it from other sources. Melanin is affected and tyrosine. And tyrosine can also be converted to like thyroid hormone. But anyhow. So the problem you should be looking for is phenyl ketone becomes toxic and lack of melanin. Only two things. With this condition, the problems will initiate because of phenyl ketones are toxic. They will cause mental retardation, microcephaly, seizures, and other issues. But of course, this you have to memorize, this you have to memorize, and then the musty odor you have to memorize, and albinism because of melanin deficiency. But of course, there's other conditions, neurological conditions, there's many. But this is what will help you. As long as, if I tell you, you know what, a child had this, and I give you a crazy scenario, and then I tell you, you know what, I did enzyme assay, and I found out phenylalanine hydroxylase was deficient, or it had decreased activity. There's no way you can think anything else. It has to be what? PKU? Yeah, done. Okay, so with the strong evidence, you don't worry what are the conditions or symptoms. Okay, so that's one thing. Now, make sure you spend time on PKU. It's common. And PKU, females who are getting pregnancy, or they're getting pregnant and they are deficient, they should be, because in female, these, let's say I'm a mom, right? I get pregnant and I have PKU. My child is at risk of these symptoms. Why? Because these phenyl ketones can cross placenta and cause damage to fetal neurons. Even the fetus is normal. So that means female who have PKU, they have to prevent or avoid eating phenylalanine rich diet about 3 to 6 months before they get pregnant. Okay, not the day they get pregnant. Much before that.
When they
Much
have
earlier.
deficiency.
If you're let me switch to you. I always want to pick up. If you're a mother and you have PKU and you want to get pregnant, you should avoid phenylalanine diet. Of course, in pregnancy 100%, but even 3 months before that, it's recommended. Because if you have deficiency, that means you will have increased phenyl ketones in your body, in your blood. Right? And that means they can cross the placenta and go where? Into the fetus and cause damage in the fetus. Okay?
I have a question.
Yeah.
So if this is caught before the child is born, can this child live a normal life if they just avoid phenylalanine diet?
See, if the child has deficiency of this enzyme, they could, yeah, they could.
If he took a diet, like.
Yeah. Assuming the mom was normal, because the fetus has no problem himself, yeah. So nonetheless, rarely, it's difficult, these children will have some sort of, yeah. Okay.
You said earlier you find ketones in the urine, right?
Yeah.
So how do they differentiate between ketone bodies to glucose not being broken down versus?
They're different ketones. The ketone in glucose is acetone, not phenylacetone. The phenyl group makes it phenyl ketones. Yeah, those are different ketones. They're hydroxybutyrate, acetoacetate, and acetone. The one we're talking about, and the normal ketone that me and you and all of us, when we're hungry, we produce them. So those ketones, memorize them, because when you reach to lipid synthesis, we'll learn them. But let me give you now, because you talk about it now, everybody's responsible for it. Just kidding. Acetone or acetate, okay, acetate, and beta hydroxybutyrate. These are the 3 ketones normally produced in our body, which is not damaging because we can handle them. Phenyl ketones are more neutrals. They can cross blood-brain barrier. They can cause problems in that sense. So can these ketones, but they can cause more reaction. Okay, they cannot be used for energy directly, in a sense. Okay.
Dr. Marie?
Yeah.
I kind of want to see if I understand it. So this
You do
whole-
understand it. You just don't believe it.
Okay. This whole thing is caused because the phenylalanine hydroxylase is blocked.
Deficient.
Okay, deficient.
Phenylalanine hydroxylase, the enzyme is deficient or defective.
Okay.
Think about it this way. You have a machine that converts phenylalanine to tyrosine.
Yeah.
If that machine is broken, not there, defective, what happens to phenylalanine?
It will increase.
It will increase. You cannot convert it. Tyrosine will become deficient,
Okay.
will decrease, and phenylalanine will accumulate.
Okay.
Okay? Yeah. Now, the problem with that is you're like, who cares? The reason we care is phenylalanine then will be converted to something toxic. If you don't use it, it accumulates, it will be converted to something toxic. And the toxic thing is known as phenyl ketones. And they will cause mental retardation, microcephaly, okay? And they give you odor. The baby, especially the baby, when you pick them up first, you will have this musty odor to them. And they will have lack of melanin and cause albinism. Isba.
What can cause the fetal acetone hydroxylase deficiency?
What can cause? Nobody knows. Yeah, it's genetic mutations. Yeah. What caused the mutation? It could be a viral. It could be a mistake in replication, right? It could be medication. It could be stress. Many things. Yeah. All right. Anything else? Good? Okay, so PKU, make sure you spend time on it and you understand it. What would accumulate and what will be deficient? Tyrosine will become essential. Phenylalanine will become toxic. And phenyl ketones will become toxic. Please understand what I'm saying. Tyrosine will become essential. You have to get it from your diet. You have to get it from your diet. Phenylalanine will become toxic. You have to avoid it. Phenyl ketones are the product of that toxicity. So you have to avoid phenylalanine and you have to eat a lot of tyrosine. Make sense? Okay. Alright. The consequences: mental retardation, microcephaly, and musty odor, albinism, and of course other neurological symptoms. And if you take a sample of urine, you will find phenyl ketones, and that's diagnostic. But further, what you can do is you can take these cells. Let's say the best cells are taken what? Skin cells. Take a sample of skin cells and look them under microscope and then do an enzyme assay on them, they will have deficiency of phenylalanine hydroxylase. Don't go into neurons and start taking neuron out. Skin is available, just take a sample of skin. So do skin biopsy. Okay. Alright, so far so good. That was PKU. Now there's another enzyme right after tyrosine. Let's say this one is normal. What's the enzyme after tyrosine?
Tyrosine hydroxylase.
Tyrosine hydroxylase. What if you have deficiency of tyrosine hydroxylase?
You can't make Dopa.
Okay. Would that back up tyrosine?
Yes.
Okay, good. Let's see, this enzyme is deficient. Now you'll have backup of what?
Tyrosine and phenylalanine, right?
Yeah, and phenylalanine. You'll have backup of that. Would that lead to PKU? Why not?
Yes,
No, we have kerosene.
doesn't matter. But
No, that's okay.
increasing that is gonna backfire and go back.
Yeah.
Feedback, you know, wouldn't allow hydroxylation of more phenylalanine.
Yeah, so if you don't consume phenylalanine, they will accumulate and will become what? Phenyl ketones. This is what you don't want. You don't want this, but it happens. As long as you have too much phenylalanine, it is likely to convert to phenyl ketones. But as long as you keep consuming phenylalanine, it wouldn't be a problem. So in this case, they will be converted to tyrosine. Tyrosine can be used as thyroid hormone and other stuff. But there's an issue that it might not give you PKU because tyrosine is consumed. Tyrosine is then consumed to something else. It is known as alkaptones. Where is L? There's alkaptone. These are alkaptone ketones. These are different ketones. See, phenylalanine is converted to phenyl ketones, and tyrosine is converted to alkaptones. Okay? And alkaptone is then converted to homogentisic acid. Homogentisic acid. Okay? And this is eventually converted to product of the TCA cycle. Eventually it will be metabolized and consumed for energy. Okay, so therefore tyrosine will never accumulate because tyrosine will be converted to what? Eventually to pyruvate and acetyl-CoA, and it will be consumed in the crop cycle. Okay, so no big deal. We haven't gone that far yet. Let's just put it this way. So homogentisic acid will eventually will be used to produce ATP. It could be used to make ATP, glucose, or lipids. So it would not accumulate because there's a pathway for it. Because there's another pathway. Okay. Whereas for phenylalanine there were only two pathways. Either become tyrosine or phenyl ketones. Now for tyrosine there's multiple pathways. One of them is this one is important. Now the enzyme here, right here, I'll use green, is known as homogentisic acid oxidase. This is an important enzyme. This is an important enzyme. If this enzyme is I was telling somebody a story that I always miss P and F. Is anybody here? Ahmed? I just almost said instead of PF. But if this enzyme is deficient, that means this reaction will not go forward and you will have accumulation of what? Alkaptone. Oh my god, crazy. Alkaptones. Are you serious? This is slowing down. Something like the upper button of the pen has been pressed. How am I supposed to hold it? Okay. Let's do this way. My pen has asthma, super sensitive. Okay. So again, if you have this enzyme deficient, that means you cannot break down tyrosine or alkaptones into products that are useful, and that means alkaptones will accumulate. These ketones, alkaptone ketones, now not so toxic as phenyl ketones, but nonetheless there's a disease named after that, alkaptonuria. Okay, so it would be deficiency of what? Alkaptonuria? Homogentisic acid oxidase deficiency. Okay, you will have less homogenetic acid, but you will have accumulation of what? Alkaptone. Now, when these guys accumulate, so they give your skin dark pigmentation. If it accumulates under skin, but they don't accumulate under skin, they accumulate usually much lower than hypodermis. So you won't be able to see. They don't accumulate in the dermis and epidermis. So usually they accumulate in joints. They'll make your joint stiff. Imagine I put salt or sand in your joints and I cut your joint or I inject these things. It'll make your joint stiff. So arthritis, you're correct. Stiffness of joint and arthritis. That's one thing.
Black bones?
Huh?
You call it black bones?
No. No. See, bones, you have to actually get in there. It's just the joint that will stain dark. Yeah. Okay, I'll come to that. Okay. So that's one thing. So you should expect for alkaptonuria, let me write these things here. So now we're talking about a disease, alkaptonuria. Okay. In alkaptonuria, you will have stiff joints or arthritis. Okay. Second thing is these ketones are found where? In urine.
Black bones? Dark bones?
Not yet.
You have dark urine when it's exposed to air.
Very good. So now, the only time you will convert alkaptone to something else is if they're oxidized. If they're oxidized. See, in this person you had deficiency of oxidase. But now when you expose alkaptone or urine to air, it will oxidize. Otherwise, it will not oxidize. If somebody pees in a little tube and then close the top, you won't see any change. Usually people wake up early in the morning and they stand up and they pee and they will see the urine turn dark upon exposure to air. So, dark urine. Dark urine. And they get scared. They think they were inflicted by some kind of creatures, an alien, jinn, or ghost, or demons and whatever.
Especially in the morning.
Especially in the morning, yeah. Yeah.
Waking up and
And then they start becoming more religious. But okay.
I'm just gonna put charcoal in everybody's urine.
So dark urine upon exposure to air, upon exposure to oxygen. Okay. Now the question is, that's all you need to know, nothing else. But could it cause other complications? Yeah. What if alkaptones start accumulating? Now, how does these ketones come to urine? How do you bring them to urine? By blood. So that means you will have them in blood too. But blood goes through heart. Remember this. Heart is one of those organs that have to pump the entire blood, entire volume of your body blood in 1 minute. Right? So the heart, cardiac output is 5 liters, which is the total amount of blood in your body. But the heart is pumped in 1 minute. Of course, the heart beats 70 times, 72 times at rest in a healthy person. So that means it will take 72 pumps to pump the entire blood once, and circulate once. That means all the blood comes through the heart. So if this alkaptone comes to the heart and they're harsh and they're rigid like barbed wires, and then the harsh pumps this blood and it splashes it against its valves, the valves can get damaged. Make sense now, Zach? Okay. And it can cause valvular damage that can lead to endocarditis. Let's leave that because that's a huge disease. We'll discuss them in cardiovascular diseases. Not next term, the term after. Okay.
So then they can damage all organs and tissues.
Yeah. Yeah. Yeah, it can. But you don't have so many of them. There's not so much huge concentration that will cause. So usually it's asymptomatic. Usually this condition is asymptomatic. The only thing is you get scared early in the morning. You think you did something wrong last night and then... Huh?
The kidney filtrate them very good.
Yeah. Yeah. Okay, so that's alkaptonuria. What are you going to focus on? Enzyme deficiency. It's autosomal recessive. What are the consequences of that? Accumulation of alkaptones. Where? In urine. And that's where the name is, you get the name from.
The urine itself is not going to be dark. It's not going to be dark. It's dark after next split.
Yeah. Yeah.
Has to get oxygen.
If somebody urinates in a carbon dioxide rich room, The urine will stay the same color.
So
It's only upon exposure to oxygen it gets oxidized. Yeah.
so it wouldn't be painful or anything.
No, urination is not painful. Okay, so they don't form stones, and if they do, you have to have the acidic environment for them, which is again other complications, right? Puts you at risk of stones, but again, it's not known a major cause of kidney stones. Okay, the reason peeing will be painful is two reasons. Number one, there's crystals, tiny little crystals that are sharp. Imagine you take a glass, you break into small pieces, and you drink it, and then you pee it. Each piece that touches the inside of your urethra it will cause pain. It will hurt. That's why kidney stones are painful. Okay. Other times when somebody has UTI or infection, and again because the urethra swells, and the bacterial product can cause burning and sensation and so forth. Right? Okay. So that's the two times usually people will having pain upon urination. So we discussed two diseases so far. Okay.
But what about formation of Dopa?
Yeah. Now Dopa can be can be made by other sources too. Not just this, not the only source. Okay. Yeah. Okay, so next thing is what? We went as far as tyrosine, right? Tyrosine. Now tyrosine can be converted to two things. One, and then Dopa, right? Let's talk about melanin first. There's an enzyme that's deficient here, could be deficient, which is known as tyrosinase. Tyrosinase. The enzyme known as tyrosinase is the most common cause of albinism. Okay, selective albinism without anything else. Okay, a common cause of albinism, although it's a rare disease because it's autosomal recessive. How many people do have autosomal recessive disease in the population? 1 in 100,000, 1 in 10,000, 1 in 20,000. The most common one is usually cystic fibrosis. I think here it's 1 in 10,000 in the United States. I think so, or maybe 1 in 30,000. But in Eastern Europe, Western Europe, it's very common. Okay, in Western Europe, it's much common. So these diseases are not common. How many people come with these conditions? Rarely. These are rare diseases. Okay. So anyhow, tyrosinase deficiency will give you albinism, which means completely white hair, completely light skins, eyebrows, every hair is light, and blue eyes, completely blue eyes. That's albinism. Okay. It's lack of melanin, but that's genetic part of it. Okay, so I don't have to spend more time on that. Just know that melanocyte will be selectively deficient in what? In tyrosinase. Now guess what? What cells should be rich in tyrosinase? Melanocytes, skin cells. Other cells should not have it. Okay, other cells will not have that enzyme. Makes sense, right? Okay. Let's move on now to something very important, and that is Dopa being converted to dopamine. Dopa being converted to dopamine. What's the enzyme? Dopa decarboxylase, right? Dopa decarboxylase. Please memorize that enzyme. Dopa decarboxylase. Decarboxylase. Dopa decarboxylase. This enzyme has two versions of it, at least that I know of. One is found in the nervous system in neurons, dopaminergic neurons. Okay, dopaminergic neurons should have this enzyme, otherwise how would they be able to produce dopamine? Right? Okay. The second version that's important clinically, maybe there's multiple, but the clinical important one is found in neurons. In the second version that's known as, so central version. There's central Dopa decarboxylase and there's peripheral Dopa decarboxylase. The peripheral Dopa decarboxylase, peripheral Dopa decarboxylase is found in plasma, in blood, and plasma. You can call it CNS Dopa decarboxylase and plasma Dopa decarboxylase, two different versions. Okay. Now the important of this is what? Well, if this enzyme is deficient in the CNS, if this enzyme is deficient in the CNS, that means you cannot make dopamine. If you cannot make dopamine, that will lead to what? Parkinson's disease. Parkinson's disease. So just keep in mind what I just said. Okay. Now the problem in Parkinson's is not deficiency of dopa decarboxylase. It is destruction of the neurons that produce this neurotransmitter. It's in Parkinson's disease, the problem is destruction of dopaminergic neurons. It's not the enzyme problem. Otherwise, people will be born with this disease, Parkinson's disease. It's not autosomal recessive. It's not X-linked recessive. This is enzyme. Everybody has the enzyme. So with time, what happens is, it is idiopathic destruction. Idiopathic means without the clear-cut cause. We don't know what exactly caused destruction of dopaminergic neuron in Parkinson's patient. We don't know exactly what. Maybe a viral infection that stays silent, no symptoms, and maybe bacterial infection, maybe diet, maybe stress, maybe this, maybe alcohol. But anyways, there are risk factors, and one of them is aging. One of them is aging. But there's no clear-cut cause. Okay, so when we don't know the exact cause of a disease, for example, PKU, you know the exact cause. Phenylalanine hydroxylase deficiency, clear-cut, determined. Okay. Published even. But now when we talk about Parkinson's, we cannot isolate or identify at this point the exact cause. So it's known as idiopathic. Idiopathic. Unknown cause. Disease that are idiopathic, we don't know the exact cause. But there's multiple things that can contribute. We can speculate. We can guess. Yeah. No, I'm just saying if it is deficient, there's no case that I know of where decarboxylase in the nervous system is deficient. There's no such thing. At least I don't know of. I'm just giving you something just for the sake of understanding. So in Parkinson's patient, in Parkinson's disease patient, there is destruction of what? Dopaminergic. Wow, how do I write dopamine? That's crazy. Dopaminergic neuron destruction. Now, if you take a biopsy of midbrain in substantia nigra, how would it appear? Pale color. Less dark. In Parkinson's, in healthy people, it will appear dark. In healthy people, it will appear pigmented. In Parkinson's patient, it will be depigmented because it is giving dark color, right? Because if you have less of dopaminergic neurons, you will have less color in that sense. Okay, so that's what it is. It's not enzyme problem. Now, why do we have to know dopa decarboxylase? Because what happens is, at the end of the day, if you have less neurons, that means there's less dopamine. If there's less neuron, because it's the neuron that produces what? Dopamine, correct? So if there's less neuron, that means less dopamine is produced. What if whatever amount of neurons we have, we supply them more dopa, and it should be able to convert dopa to dopamine? Yes, it will eventually to increase in dopamine, and that seems to resolve Parkinson's symptoms. So for Parkinson's patient, you give them L-Dopa. It's a medication in the medication form. You give them L-Dopa. The L-Dopa, when it goes to the nervous system, the central dopa decarboxylase was converted to what? Dopamine, dopamine, dopamine. And now you have enough dopamine. The symptoms are resolved. Okay? You have enough dopamine and the symptoms are resolved. You might say, why don't you just give them dopamine? Why do you have to give them L-Dopa? See, dopamine, GI is responsive to dopamine. Kidneys can respond to dopamine. If you just give them dopamine, that means what will happen? You will have side effects. First of all, less will reach the brain, most will be used by the rest of the body, and you will have side effects. We don't want that. So first, give me a second. First, L-Dopa is a great drug, and you have to combine this with something known as Carbidopa. Carbidopa. Usually the drug is given in combination of L-Dopa, Carbidopa, L-Dopa, Carbidopa combination. See, Carbidopa is not central. It cannot cross blood-brain barrier. Carbidopa cannot cross blood-brain barrier. Okay? But it is plasma decarboxylase inhibitor. Carbidopa is dopa decarboxylase inhibitor. It blocks the activity of dopa decarboxylase. So when people take it, and it will increase in blood it will inhibit what? Dopa decarboxylase, but it cannot cross blood-brain barrier, so it wouldn't be able to inhibit central decarboxylase. What you're doing, Carbidopa prevents conversion of dopa to dopamine in blood. Carbidopa prevents conversion of dopa to dopamine in plasma. Okay, let me just slow down.
Yes, please.
So, in Parkinson's patient, there is decreased dopamine. That's a problem. How can we restore that? Well, let's give them dopamine. That's one solution. But if you give them dopamine, dopamine also acts on other parts of the body. Good? So it's not a good idea to give them dopamine. So instead you give them L-Dopa. L-Dopa is a precursor to dopamine. L-Dopa is a precursor to dopamine. Okay? L-Dopa is a precursor to dopamine. So if you give them L-Dopa, but you have plasma decarboxylase. Plasma L-Dopa decarboxylase. So if you give them L-Dopa, your plasma decarboxylase can convert dopa to dopamine. It's almost like giving them dopamine. What's the difference? So let's use an additional medication known as Carbidopa. What Carbidopa does, it blocks plasma decarboxylase. Carbidopa. Write it down first, then read it, and then you'll get it.
Peripheral decarboxylase.
Yeah. So, Carbidopa blocks plasma decarboxylase, dopa decarboxylase. So if your plasma decarboxylase is inhibited, that means dopamine cannot be produced from dopa in blood. In blood. Most of the dopa will have to now go across the blood-brain barrier, and only in the brain it can be converted to dopamine. So you're simply choosing the smooth passage of dopa into brain, and there it's converted to dopamine. And concentration of dopamine in the brain will increase, and Parkinson's symptoms will be relieved. Okay? At the end of the day, you simply what you're trying to do is prevent digestion, conversion of dopa to dopamine in blood. That's the whole idea. And who does that? Carbidopa. Carbidopa. Nina, you had a question, and then Malcolm.
I was going to say,
It's resolved? Malcolm.
Where does salicylic play a role into, because I remember you said that was the best choice of medication besides, and not L-Dopa.
Who said that?
I thought you said that on the example test. Yeah.
Under circumstances.
Okay.
Not always. Yeah. Saligilin is monoamine oxidase inhibitor. We haven't got there yet.
Oh, that's why.
Yeah.
Too far ahead.
You're too far ahead.
Okay.
You gotta hold your horses.
that's
Yeah.
that's my
Okay. Now, saligilin is used in patients who have young patients who have Parkinson's. It helps them. Patients who have full-blown Parkinson's is useless. Yeah. Okay. But Carbidopa, L-Dopa is the drug of choice. Okay, the drug of choice for Parkinson's patient. You're just simply replacing what's deficient. What's deficient is dopamine. Now, the side effect of dopamine will be what? Yeah, same thing. Psychotic behavior? Yeah, sure, that's in the CNS, but more GI problems, diarrheas, and increased motility, and pain, and so forth, and renal problems. That's what, because you will have some of those, but in small concentration, no big deal. Okay? So this is, you need to know dopa decarboxylase. Dopa decarboxylase, because Parkinson's is a huge disease. Huge disease. Okay? Now, I want to make sure that you understand that decarboxylase, dopa decarboxylase will produce dopamine, but in Parkinson's, they're not deficient. It's the neuron that is destroyed. Okay? One more thing. If you have too much dopamine, naturally, it will lead to psychotic behavior. Maybe people who have, maybe, I'm guessing that, there's no evidence as far as I know, maybe people who are prone to psychotic behavior, they will have increased activity of what? Dopa decarboxylase in the CNS. Or maybe they express too many enzymes in this category. Let's say normal concentration in one human being in healthy people should be, let's say, for the sake of argument, 100 of dopa decarboxylase in the CNS. In psychotic people, maybe it's 1,000. Now they have more tendency to produce more dopamine. But again, the dopa decarboxylase, when we talk about psychotic behavior, is not in substantia nigra. It is in the frontal lobe. Okay, so each area has its own functionality, right? Okay, so in this case, it's possible. I don't know. I'm just telling you, but it's clear-cut evidence that in psychotic behavior patient there is too much dopamine. So what are you going to use? Dopamine receptor antagonist, anti-dopamine. Okay, dopamine receptor antagonist. Okay.
This is not related to the decarboxylase deficiency.
No. So we're done with that. So what I'm saying now is, if there's too much dopa decarboxylase activity, somehow you produce locally in one area of the brain or other area of the brain too much dopamine, maybe you can use anti-dopamine. Okay.
It will affect the brain, like, will give symptoms like Parkinson's?
No. Parkinson's, the dopamine is deficient only in substantia nigra. You have many areas in the brain that can produce dopamine. Okay. Now, so that's one thing. Now, the side effect of dopamine antagonist will be what? Depression. If you use too much, it can cause depression. Also, there's one more thing. We're going somewhere else. There's a gland known as pituitary gland. Pituitary gland. Pituitary gland produces prolactin. Prolactin. The production of prolactin is usually blocked. There's a gatekeeper, and the gatekeeper is who? Dopamine. As long as you have enough dopamine, prolactin will not be produced. Okay? Now, when you take antipsychotic medication, what does it do? It blocks dopamine receptors, and you will have increase in prolactin. So the side effect of antipsychotic medication is always gynecomastia. Gynecomastia, which is female-like breast in men, because it increases prolactin, and galactorrhea. Galactorrhea. So let's do this. Galactorrhea. Galactorrhea and gynecomastia. So know that if you use medication that blocks dopamine receptor, it can also block dopamine receptor in the pituitary, and as a result prolactin production will increase, and prolactin causes milk production. Okay, milk production. So in men, it will be, the breast will enlarge, become more like female, and it will release milk. In female, it will be only galactorrhea. Anterior pituitary. Anterior pituitary. Okay? Yeah.
And man is asking if you can elaborate on dopamine and L-Dopa and Carbidopa being able to cross the blood-brain barrier.
Only Carbidopa cannot cross.
Dopa and L-Dopa both can.
Yeah.
So dopamine is still crossing.
Yeah. Yeah. L-Dopa can cross, dopamine can cross, yeah.
Question.
Yeah.
So if you don't give it in connection with Carbidopa, then it would just digest in peripheral, right?
Mm-hmm. Yeah.
And that also causes side effects.
Of course. So now that will cause constriction of your kidney and cause hypertension. It will increase activity of your GI. Okay? Secretion and so forth. Okay, so that's for this. Further thing, there's one more thing. In depression, there's lack of dopamine. Depression, so decreased dopamine. Decrease in dopamine leads to depression. Okay? So that means you can give something to increase dopamine activity somehow. Not L-Dopa and Carbidopa, you give them a receptor. You give them something that will inhibit COMT or MOOI. Let me get there first. Let's just ignore it for now. Let's go to that point. The next thing I want to talk about is Pheochromocytoma. And then after that, I'll talk about depression. Pheochromocytoma and Neuroblastoma. Pheochromocytoma and Neuroblastoma. Let's keep it simple. Pheochromocytoma simply means tumor, mass. Oma means what? Mass. Oma. So you should learn this terminology to make your life easier. Whoa, okay. Oma means mass. or growth. Cyte means cell. So cytoma means what? Growth of cells. Cytoma, mass made of cells. And then chrome means what? Color. Pheo, I don't know. Maybe because phenylalanine? I don't know. So pheochromocytoma is a mass that can produce color when you look under the microscope, or dark color. Okay, in that sense, because of pigmentation of epinephrine. But pheochromocytoma is, please remember that it is adrenal mass. Adrenal medulla mass. It's a tumor of the adrenal medulla. It's a tumor of adrenal medulla. You can call it cancer in this case. Cancer of adrenal medulla. Hyperplasia, growth, neoplasia, whatever you want to call it. Nonetheless, it is abnormal growth, too much growth of the adrenal medulla. So it's cancer of adrenal medulla. Okay. Neuroblastoma, same thing. Same thing. Majority of these, you see, we haven't talked about sympathetic nervous system. Sympathetic chain ganglia has the same cells, so sometimes it could be paraganglioma. Paraganglioma. But just write it down and just memorize it, don't worry about it. Paraganglioma has the same thing, but it's not in the adrenal medulla. It is outside of the adrenal medulla. It is part of sympathetic chain. So let's just say paraganglioma. Paraganglioma. Ganglioma, right. Paraganglioma is a mass of the sympathetic chain. Sympathetic nervous system is responsible for the flight or fight mechanism. So you can have a mass in those areas, which is rare, but it's most likely common in neuroblastoma and this. Now, let me quickly write this down and then I can tell you. Neuroblastoma is only in children. Pheochromocytoma is in adults. Okay? It's the same mass. The same thing. In children it's called neuroblastoma. In an adult it's known as pheochromocytoma. That's all. It's the exact same thing. It's mass of the adrenal medulla. I quickly have to tell you something, so please forgive me for this to make your life difficult. Adrenal gland sits on top of the kidney. Okay? Whoa, that's horrible. I usually don't draw like that. It sits on top of the kidney. Okay, so it looks like a Murph, you know those Murph, Papa Murph, whatever their hat. Is it Smurfs? Those of you who are listening to me. Smurfs, or I'll just call it French hat. How about that? You know, French people have this kind of hat. Now, adrenal gland has medulla, which is the core. I'll color it blue. The core of all solid glands, not glands that have an empty space within them, like lungs or chambers of the heart. Solid glands, they will have a core and cortex. Okay, so yellow will be called the cortex. Yellow is cortex. I knew it was leaking. Wow, this is becoming super sensitive. So yellow is the cortex. Okay, and blue is medulla. I don't want to spend too much time. I'm just telling you that medulla is what produces epinephrine and norepinephrine. But of course we said epinephrine. Very good. Roughly speaking, don't quote me on it. Guyton says 85, so I don't know. And this is roughly speaking 10%. Now, the cortex produces three things: aldosterone. It's a great idea to memorize them now. Cortisol, especially we'll talk about it next week. And androgens. So adrenal gland is a major neuroendocrine gland. The cortex is endocrine, medulla is nervous tissue. Okay? So epinephrine or epinephrine are what? Neurotransmitters. Aldosterone, cortisol, androgens are what? Hormones. Steroid hormones. Let's just categorize them to make your life easier. They're strictly called what? Corticosteroid hormones or steroid hormones. Androgen is male sex hormones like testosterone. These are neurotransmitters. Neurotransmitters. Okay, so this is a simple knowledge, but it will help you a lot. Just keep that in your mind. Okay. Now, let me erase all of this and keep this part. The question is, if pheochromocytoma is a mass, abnormal mass. See, when we say OMA, I'll make it red. OMA is a mass that does not respond to negative feedback. Please write that down. Whenever you have adenomas, adenoma means a tumor that is in shape of gland or epithelial tumors. OMA, whenever you see this term OMA, means abnormal growth. Cancers or tumors. What is the difference between tumor and cancer? Cancer can spread, metastasize. Tumor can be cancerous or non-cancerous. Okay, so let's just use the term tumor for now. Tumor, usually benign tumors that don't travel will end with OMA. The term OMA means benign tumors. It has no ability to invade or travel or spread. So it's not cancerous. It's just a growth. All tumors, especially epithelial tumors, and generally speaking, most tumors are autonomous, independent of the local tissue that surrounds them. They're independent. In what sense? They don't respond to negative feedback. All tumors, or actually, you never know, there might be something, I'm not going to say all, majority of the tumors, most tumors are autonomous or adenomas. The best thing is, let's write this. Most adenomas. Let me write it down. Most adenoma most adenomas are autonomous. Autonomous means, in this case, means they don't respond to negative feedback. They don't respond to negative feedback. Okay, so no negative feedbacks. No negative feedback. Wow. No negative feedback. Good? Are we good with this? Keep that in mind. This will help you a lot later on, even today. When I tell people later on, they're like, okay, it's later on. Let's just not today. We want immediate rewards, right? Okay, so now, regardless, if the mass is in the adrenal gland in children, it's known as neuroblastoma. If the mass is in adults, it's known as pheochromocytoma. Are we good with that? Okay. The age for neuroblastoma is usually under 2. Usually it's 2 years old. Usually. Okay. And the mass can become so big that it can actually, you can have abdominal distension. For neuroblastoma, the mass can enlarge, become 1 kilogram. You know when babies are born, how much does a 2-year-old weigh?
2 kilos, 3 ounces. 2 to 3 kilos. 9 pounds.
No, 2 years old. 2 years old. 2 years old.
2 years old.
Not 2 days. I got confused.
Since you born.
It's a new year. Yeah, I said that, and it's at 2 years old.
Okay. I would say about 20.
About 30 pounds, 20 to 30 pounds.
2 kilos.
Yeah. So imagine they have a mass of 1 kilogram in the abdomen. It's going to be a huge bubble. So look for abdominal distension. I'll tell you that again anyway. So anyways, there's a mass. This mass does not respond to negative feedback. That means it will continuously keep producing what? Epinephrine. It's a functional, so it will produce too much epinephrine. That's a problem.
This is in neuroblastoma?
In both.
Oh, both
Yeah.
look less size.
No, in pheochromosome it doesn't grow that much because adults, they're more mature. The tissue is not neoplastic so much, but both will produce epinephrine. Yeah. Okay. So number one thing, this mass will start producing epinephrine, a little bit more epinephrine, but that little bit, that 10% now, if you think about it, normally it will produce 100. Now it's producing 10,000. So even that 10% becomes 100% norepinephrine. So at the end of the day, you will have both. But our focus will be on what? On epinephrine. Okay? On epinephrine. Now, the thing is, adrenal medulla produces epinephrine or norepinephrine or these adrenal or adrenaline in pulsing non-continuous formation. It produces it and it stops. It produces it and it stops. It produces it and it stops. All the symptoms should be based on that. Once you know it's adrenal medulla tumor, and you know that adrenal medulla can only produce what? Adrenaline and noradrenaline, that's all. And you know the function of adrenaline. What does it do? Increase your heart rate. Let's write it down. So the symptoms should be tachycardia. Yep. Tachycardia. Okay. Now, people can actually feel tachycardia. They can complain of tachycardia. They don't know what hypertension is, but it does cause blood pressure. Yeah, I'll come back to that. So they'll have tachycardia. Anything else? Headache. Now the headache is because of hypertension, increase in blood pressure, increased blood flow to your brain. When there's too much blood flow to your brain, what happens to the vessels? They're pushed out, and when they push against your brain tissue, it will cause headache. Okay, anything else? Palpitation. What is that? What is palpitation? I can relax now. You guys tell me.
Heart flutter?
What's flutter?
It's like quick beats.
Yeah, but
Patient will tell
you can't
that
see
I
that.
feel my heartbeat.
There you go. What was the second term?
Awareness.
Very good. Heart. Feel. Palpitation. When you palpate a patient, what do? You touch them with your hands. And when you touch them with your hands, are you looking for color? Are you looking for smell? What are you looking for? Can you feel something? Yeah. Palpitation, when you feel your heartbeat. Not only you hear it, you feel it. You feel it. It's louder. It's much stronger. So palpitation. You can have increased heart rate and not even know anything about it. Only time is when you take your pulse, you say, oh, my pulse is high. But palpitation, you actually feel it. Okay? So tachycardia, headache, palpitation. Anything else? Well, tell me all the symptoms and signs of flight or fight. Sweating. How could you forget? Yeah. Somebody sitting in cold, just sitting, and they're sweating. Suddenly. Yep. In winter, they should not sweat. So the questions, when it comes, they will tell you, like in a cold temperature, somebody was sweating. And there's no indication of infection at all. Anything else? Of course, wakefulness, focus, alertness, and maybe insomnia. But all of these symptoms are they continuous or? Pulses. And the term for that is paroxysmal. Coming and go, comes and goes, come and goes. These are episodic. These are episodes of these. Okay, you don't always have these symptoms. Whenever you release a lot of these neurotransmitters, you will have the symptoms. Okay? And then between them, normal. Okay. So you will please focus on three things: tachycardia, palpitation, and sweating. Those are the things you should focus on. I mean, headache is good too. Oh, same thing. In adults and in children. But in children, there will be something additional. In children, so let me increase the mass. In children, there you go. I didn't say anything yet. You can say whatever you want. Okay. Now, in children, you will see what? You will see abdominal distension. Abdominal distension. In a 2-year-old. You don't expect that. So in both cases, you will have abdominal mass. But in Pheochromocytoma, usually the mass is small. But in children, usually the mass can get larger. And the mass can cross the midline.
Is it both sides or one?
Unilateral. Yeah. Okay. In adults, this condition is associated with something known as MEN. Those of you who took MEN in endocrinology, yeah, it's especially associated with MEN1, Pheochromocytoma. Okay, and it's autosomal dominant. It's inherited. MEN1 is inherited. So there is an inherited version of Pheochromocytoma. In children, it is not inherited. But anyhow, so abdominal distension plus those symptoms. Now, if you do CT scan, you will see a mass. Where would you see this mass? In the abdomen. Do you see a kidney right now?
No.
No. So be careful. If you're told that you see renal mass, then this term misleads you. It tells you what? As if the mass is from the kidney. But it's not a renal mass, it's suprarenal mass or adrenal mass. Suprarenal because it sits on top of the kidney. As long as you have increase in epinephrine or epinephrine, it cannot be renal mass. It should be suprarenal or adrenal mass. Because it can get so big that you might not be able to see kidneys. You think it's from the kidney. Or let's say let's do this. If the mass, there you go. The mass is so large that it takes all over the adrenal gland. Now you think what? You think it's a renal mass. You think it's protruding from the kidney. So you can see the kidney and you see something sticking out. You don't see the adrenal gland. So people make the decision, they say renal mass, as if it comes out of the kidney. Okay? As long as it produces epinephrine or epinephrine, it is not renal mass. The origin of this mass is what? Adrenal medulla. Not even adrenal cortex. Adrenal medulla. Be very specific.
Any renal dysfunction?
Yeah, it can lead to, yeah. Okay, so that's what you should be looking for these two. Okay, so mass, abdominal distension, and this one is malignant. This one is very aggressive in children. It can travel to lungs, to bones, to brains, and to, of course, first it will travel where? To the kidney. Okay, so it can metastasize, and it has different stages, stage 1, 2, 3, 4. Of course, stage 4 is the advanced stage, it's worse. That means the mass has traveled to many parts of the body. Maybe by then it's lethal. Pheochromocytoma is only 10% malignant, 90% benign. Whereas neuroblastoma is the opposite. Okay, there's the rule of 10 when it comes to pheochromocytoma. 10% of population, I think they say in some cases. 10% is bilateral, 10% is malignant, which means automatically 90% is benign. Okay, so don't ignore the other part too. Okay, you should be able to recognize. Again, I'll go over these diseases again in endocrinology. Okay, because these are endocrine in origin, but just know for now, differentiate between pheochromocytoma and neuroblastoma. Know their symptoms and signs. And of course, know their biochemistry, which is the most important one. Which enzyme should be increased in these two tumors? Which enzyme activity?
Increased or decreased?
Increased. Which enzyme activity?
Oh, activity. Dopa. No, Dopa.
Methyltransferase. Methyltransferase. So the conversion of norepinephrine to epinephrine is increased. Because they produce mostly what? Epinephrine. Okay, so you'll have increased activity of this enzyme.
Doctor, I still don't get it. So, why the enzyme activity increases?
Okay. These two tumors,
Production increases.
yeah, adrenal medulla, I'll tell you, very good question. Adrenal medulla produces what? Epinephrine, norepinephrine. These two conditions are abnormal growth of adrenal medulla. So when the adrenal medulla grows in size, in number of cells, used to be 100 cells, now it's 1 million cells. Each cell is producing what? Epinephrine. So shouldn't the concentration of epinephrine increase? It does. Now, how do you make epinephrine? Epinephrine is made from conversion of norepinephrine. So this is why the enzyme that's here, its activity and concentration have to be increased overall compared to a healthy person. If it wasn't, you wouldn't have epinephrine. Does it make sense?
How would the production increase as production only increases the enzyme?
Okay, let me do it one more time.
Originally,
Let's do it in a healthy person.
Okay.
Okay.
Medulla produces norepinephrine originally, and then
Convert to.
converts to
Yeah.
epinephrine.
Remember you told me earlier what percentage of the adrenal product is epinephrine, what percentage is norepinephrine?
90, 10,
So 90 is epinephrine and 10 is
norepinephrine.
norepinephrine. That means almost all norepinephrine is converted to what? To epinephrine. Otherwise you can't make epinephrine. See, this is a precursor. Norepinephrine is required for the synthesis of epinephrine. It's a precursor. So the enzyme that will do this conversion is known as methyltransferase. Has to be increased in concentration and in activity in these diseases compared to a healthy person. Make sense? Yeah. Very good, very good. Okay. Now, at the end of the day, you can do CT scan of the abdomen. You will see a mass in the abdomen, and you combine that with the symptoms, you will 100% be sure that this is Pheochromocytoma if it's an older person, adult. If it's a child, you will think of neuroblastoma. Are we good with that? So now, if you have too much epinephrine, then your body can break it down and convert it to what? Phenyl mandelic acid or metanephrine. So these products should increase. These products should increase. Which means the activity of COMT and monoamine oxidase should be increased, especially COMT. Monoamine oxidase is mostly related to the CNS. Okay, so COMT should be increased. That means when these products are increased, see, when you produce epinephrine or epinephrine, or for that matter anything else, and they have done their job, what are you going to do with it later on? Exactly, clear it out of the body, detoxify them, convert them, and that's what you did. You converted into a metabolite of epinephrine, which is VMA or metanephrine, and they have to be somehow excreted out of the body, either through urine or through stool, but this is actually cleared by the urine. So in urine you will find these. Urine sample will tell you this, and that's a good test to determine. So now we're looking for three things. A 20-year-old comes to you, let's say the exact age, a 40-year-old comes and complains, you know what, doc, I get these headaches. Suddenly I get headaches, followed by sweatings, tachycardia, palpitation, and you measure the blood during this episode, the blood pressure is high. But between episodes it's normal, right? No symptoms between episode. And then you're suspicious. You do CT scan, and you find there's a mass in the abdomen, and you localize the mass to where? To the renal, to the kidneys. Okay. Further, you're still not satisfied. Like, you know what? Let me take a sample of urine, and you find what? Metanephrine, VMA. There's only one conclusion you can make at that point. If it's adult, it should be pheochromocytoma. If it's a child, it should be neuroblastoma. If you're still not sure, you're going to take a needle and you're going to aspirate some tissue from this mass, and you'll look under microscope and do an enzyme assay. You'll find that this mass is rich in what? Epinephrine, norepinephrine, or methyltransferase activity, and that's confirming everything. Done. The mass comes from adrenal medulla. Okay. All right, let's take a break.